Ok. Pessoal, a gente já vai começar, estamos aguardando o Giovanni aqui. Ele já está com a tela compartilhada.
Okay. So
Ok.
whenever you're ready, we can
Ok.
start.
We have started streaming.
Perfect.
Ok.
Okay.
É, boa tarde a todos. Estamos aqui com o segundo episódio do Pancreascast, com um convidado internacional, o professor Giovanni Marchegiani, da Universidade de Padova, na Itália, que é um especialista em cirurgia pancreática e tem a sua linha de atuação e pesquisa muito ligada ao estudo das lesões císticas do pâncreas. Então, ti ringrazio, Giovanni. Thank you, Giovanni, for accept our invitation. It's a pleasure to have you. I am a fan of your work, and I'll be glad to hear, and we can talk about your experience concerning the study and treatment of pancreatic cysts. So, Giovanni, please, the word is yours. Thank you.
Thank you, Eduardo. Muito obrigado. Unfortunately, my Brazilian words are not so many, so I'll have to deliver this talk in English. But let me say I love your accent. I love the way you pronounce my name. And for
Okay.
the few times I've been to your country, I always had great experiences, and I really love your culture and the way you look at life, guys. So I mean, I'm really honored to be virtually with you today. So the topic that we're gonna talk about today, as Eduardo said, it's regarding IPMN of the pancreas, and we're gonna see whether it's true that in Italy we have a certain attitude towards this entity. You see here in a picture, IPMN became so popular that they even do meme now about IPMN. This is an old guy with multiple side branch IPMN. Let me see if I can show it to you with this pen. And what the guy is holding here is a cup of coffee, which means, is it true that, as for other Italian stereotype, namely drinking espresso or eating spaghetti, do we watch all VDIPMN? Is this the way forward? Let's see. And let's see also if we're gonna use some Italian gestures like this one, which is very important in my country to add some spice to your talk, to your conversation. So allow me please to do that during the course of the next 30 minutes or so. And as Eduardo said, I now work in Padua in a hepatopancreatobiliary team at the university. But this guy here, maybe some of the surgeons around the table know him. He was a legend of pancreatic surgery throughout the world, and I've been with him for 14 years in Verona. And the name is Professor Claudio Bassi, who unfortunately passed away last year. And not only he trained me during every single day of these 14 years, he also brought me into this international study group for pancreatic surgery that is all about defining a complication after surgery, grading a complication, eventually treating a complication. So it's really a philosophical way to look at pancreas in a critical way. I'm so honored that I became, thanks to him, the secretary of this study group. And with the same philosophy and mentality, I then, as Eduardo said, moved to Padova, which is the oldest school of medicine in my country, founded more than 800 years ago. In these slides, you see the anatomical theater, which is a masterpiece dating back several hundreds ago, where they used to do anatomical studies like the one done by this guy here. As you know, the name is Johann Wirsung. So, of course, he was not a German soccer player. He was not playing football in Padua, but he discovered the name of the duct named after him. So the main pancreatic duct. And it's something that you can see if you then come to Padua to appreciate all the things that not only this guy, but also others discovered during their stay in our university. So please welcome for this. So when it comes to IPMN, I think that there is one data that we have to keep in mind. In Brazil, like in Italy, we are actually experiencing a boom in terms of epidemiology. Studies like this are showing us a very important concept. The concept is the more we scan the general population, the more we find cysts, most of them being IPMN. So we still don't know the actual incidence because the more we scan, the more we perform MRI, CT scan, the more we give our radiologists some job to do, the more we find this cyst. So it's really important to know what to do if we consider a prevalence which is as high as 12% in those above the 7th decade of life. So after the age of 70, we know that millions of people, no matter which country, will have an IPMN in their pancreas. So what to do when these numbers are so big? Well, first of all, we need to classify this entity, and that's why I learned this process from the ISGPS attitude in classifying things. And depending on when the IPMN is located, then we identify either those in the main duct, the one discovered by Wirsung in Padua in 1643, and those in the branch duct, namely BD-IPMN. Does this make a difference? Well, it does, because from original studies, old studies, we know that the profile of cancer in this entity is strongly different, being the main duct IPMN associated with higher rates of cancer in surgical series. So there is no doubt that main duct IPMN are surgical candidates. So when we find main duct IPMN, we should go for surgery. But pay attention, because we are now in 2024 and we need to deliver, I would say, more elaborated message. Main duct dilation, as it might occur in chronic pancreatitis or ectasia in the duct, when it's the only feature present in our image, does not equal main duct IPMN. So if you only see a dilation on the duct, dilated duct alone, as we show in this paper on the BJS several years ago, doesn't equal a diagnosis of main duct IPMN. So be careful and take your time to get the best diagnosis that you can for your patient. For example, ask for endoscopic ultrasound, as there are endoscopists in the room, as Eduardo told me. So what about the risk of cancer in BD-IPMN? There is one number you should always bear in mind, which is 3%. Why? Because 3% is still the mortality of a Whipple resection at centers of expertise. And the overall malignancy rate of BD-IPMN does not even reach this 3%. So this already tells us that liberal policies for surgeries in this entity are not justified anymore. So patient selection in BDIPMN is actually critical. And the literature is very difficult to be dissected because depending on the perception, as in this Indian tale that I showed you, we have different rates of so-called malignancy. If you go to surgical cohorts, then you might have very high rates of cancer. But this depends on the patient selection. So this data is telling us how good a gastroenterologist, a surgeon, a pancreatologist is in selecting the candidates for surgery. But when we have big studies like population-based cohorts, you see that the risk of having a cancer is actually extremely low if you take all the cysts into consideration. So let's go back to biology and let's focus on the adenoma to carcinoma sequence, which is the same as in the cancer of the colon, and reminds us that the ideal goal for surgery should be being here in between. So detecting the high-grade IPMN. Because in this way, if we are following up a patient and we follow this in radiology and in final pathology, then it means that we did a good job in selecting our patient. Is it easy? Sometimes it is, because the different guidelines that we have, namely the European, the international, the American, I'm sure there will be also a Brazilian one I'm not aware of, but it's crazy how many guidelines we have regarding IPMN, are very good in detecting the candidates for surgery. They have a very good sensitivity in these patients. What is actually extremely important to detect is mural nodule, the solid component on IPMN. Those are, as we showed in this paper in 2018, the true predictors of high-grade dysplasia. But when mural nodules are not present and other features are present, namely warrism feature or relative indication for surgery, there is actually a lot of confusion. We don't know what to do. We have no clear-cut evidence when it comes to this IPMN based on the lack of randomized control studies and other data regarding the true malignancy rate. So a general concept that I can leave you with is already this one. When you have this relative indication for surgery as per the European guidelines, try to avoid judging the cyst from a single picture, namely one CT scan, one MRI, and try to watch the patient over the time. Watch the movie that is provided from picture to picture to picture. That is the only way to depict the biology of this cyst. What do we find if we analyze dynamically this cyst? We end up with a traffic light, you see, that is telling us one very important thing. It is not that worrisome to have a feature that is stable, as in this case. Yeah, we have a risk, but the relative risk is actually higher if you go from nothing to high-risk stigmata or from a worrisome feature to a high-risk stigmata. So the evolution of this cyst is actually the best predictor of malignancy, and you can only achieve this if you follow up these patients on a 6-month or 1-year based on what the features are. This is a very important message to be kept in mind. So bottom line, we end up watching the, have it here. This is the so-called movie of IPMN. Always at every single checkpoint, you have to ask yourself whether the lesion is stable or not. Because if the lesion is not stable, then you go back to the first observation, asking yourself whether there are criteria for surgery or for endoscopic ultrasound. We cannot do endoscopic ultrasound on every cyst, but whenever we have these criteria for endoscopic ultrasound, then we have candidates for this very, very important tool that we have right now. But if the answer is yes, the lesion is stable, you can keep watching your patient years after years, and then you will end up having, unfortunately, another question, probably even more important and even more difficult, which is how long should we keep following this IPMN? Will there be an end of this follow-up? And I hope that I will provide you an answer until the end of this presentation. So, according to this data, probably yes. I mean, we should be relaxed. We should just watch and wait this IPMN, right? Probably not. Because if we apply this policy, these are data coming from Heidelberg, which is the biggest center in Europe for pancreatic resection, then you end up having this either too late or too early resection policy, which is dangerous. Because in this series, our colleague found that 1 out of 3 of these IPMN are already cancer when we eventually go for surgery. So this is actually very worrisome indeed, right? It means that we have to be more proactive. Does it mean that we have to operate more? Again, we should be very cautious. I show you now a case report. And I know that a case report is just a case report, but I think it really tells us a lot about the biology of this cyst. We operated on a case in 1997. Back then, to find a low-grade IPMN was indeed a success because the patient survived. But in that surgery, I was not obviously there, they left a small piece of the uncinate process closed to the cyst. And this actually grew and gave us the opportunity to watch what happens to an IPMN if we leave it inside after having the pathology report of the index surgery. And guess what happened after more than 2 decades? The cyst grew, C90.9 went up, so we had to go for surgery again, and we took out the cyst again. So we were very curious whether this cyst was evolving towards a cancer, and surprisingly, we found that in 2019, it was again a cyst with low-grade dysplasia. So again, this is just a case report, but the message is, do not please believe that all these cysts will likely evolve fastly towards a cancer, because this is not the case. And luckily, we have now even evidence for that, that we know that we have to consider a cyst in a more, let's say, philosophical way by stealing some concept from the quantum physics, when in the experiment of the quantum physics cat, this was either alive or dead until we open the box, which is like the belly of the patient. And this paper, who just came out from the Dutch colleagues in gastroenterology, finally modeling the evolution of IPMN, tells us that even high-grade dysplasia can last up to 6 years. 6 years. So are we really sure that high-grade dysplasia is the true target of our surgery? If I tell you that in the meantime, a patient gets sick, a patient is now 85 years old. So it does tell us probably that we have to completely refine our indication for surgery, looking at the true biology of IPMN, because high-grade dysplasia might not be the right target for our surgery, because it is everything about the biology. It is everything about the progression pathway of IPMN depending on the genes. And again, if I show you again these slides where I told you that the goal should be high-grade dysplasia, well, let's see what happens whenever we have an evolution, okay? Now we have the genetic pathway and we have the evolution from low-grade to high-grade dysplasia. What happens when this is not progressing to cancer? What about this lesion remaining stable year after year? So no mutation, okay? Those lesions remaining always the same. This is a complete different story. And I used to refer to this lesion as trivial IPMN. What do I mean with trivial IPMN? I mean those cysts, I'm sure Eduardo has experience on that, that remain stable year after year. They never change. So remember the movie, okay? So every checkpoint, same. It's like Tom Cruise, right? I mean, you can shoot another Top Gun movie in 2050, he will always look the same. Those are the trivial cysts. So we started to study this entity back in 2018. We gave this cyst a name, and we found, I will make long story short, that even in the validation of this cohort, yes, there is always, of course, an evolution of some cyst. Even the trivial cyst will evolve after 5 years, you see. 14% will do after 5 years horizon feature, 2% will do high-risk stigmata after 5 years. But what if after 5 years, I assess the risk of having a cancer compared to the general population? Because this is what surveillance is about, assessing a relative risk. We all have a pancreas. We all have a risk which is not zero. So what about the relative risk of this cyst? Well, overall, the risk is higher, but in individuals who are already above 75, the risk is not higher. So again, take this data with caution. Again, I'm saying that if a cyst remains stable for 5 years, it doesn't mean the risk is zero. It's not zero even for chronic pancreatitis. It is indeed 22 times higher than trivial IPMN to having a cancer if a patient has chronic pancreatitis. Would we do surgery for chronic pancreatitis to prevent cancer? I don't think so, right? So for trivial IPMN stands the same concept. So stability for 5 years, cyst of 3 centimeter, patient 75, endosurveillance. Stability for 5 years, small cyst, 15 millimeters. So maybe not even a BDIPMN. Maybe it's just a duct, okay? And the patient is only 65. Again, the risk is not higher than another guy of the same sex who is now 65. So we should really start consider discontinuing the surveillance in these individuals. But what about the cyst evolving? And that's the last part of my talk. If a cyst evolves, it means that we have mutations, okay? So KRAS, GNAS, CDKN4, so those genes are adding up and they are providing an evolution of this cyst. What if I tell you that now, thanks to new analysis in the cyst fluid, we can predict which cyst will actually evolve? We have now many papers, unfortunately not in the practice, but that's what I look for the next future with DNA, microRNA, protein, cytokine. That's the only way to predict what's going to happen to this cyst. And if I tell you that thanks to this test, probably even with artificial intelligence, so we can integrate CT scan, MRI, artificial intelligence with the machine learning of these biomarkers, we identify a cyst which is going to evolve. So isn't this a target for surgery? I would say so. So we can even shift this to an earlier surgery only in this cyst that will evolve, and the vast majority of cysts either will never get surgery or they will not even get MRI or CT scan if we know about the biology. That's the only way forward to avoid unnecessary surgery, but even to avoid unnecessary surveillance of millions of people, which is not sustainable for our system. So there are, of course, some stereotypes about Italian, and they are absolutely true, but not the one that we just watch IPMN. In this case, I would say that we should now stop surveillance on the trivial IPMN. Once again, IPMN stable for 5 years. For 5 years, no feature, nothing happens, and the patient is now 75. But we will be in the future more aggressive as surgeons, and we should operate earlier only on those cysts who will eventually get into cancer. How am I saying that? Again, biomarkers, cyst fluid analysis, artificial intelligence for MRI. This is the future. I hope I can give you an update anytime soon about the topic, but by now, I thank you all for your kind attention, and I look forward for any debate or question following up. Thank you.
It's muted. It was muted. Thank you very much, Giovanni. It was excellent as always. I've seen your presentation in the Pancreas Club on Padova, and it's really something we should think about these concepts, especially to overthink the guidelines. Né?
Yeah.
As you said, the guidelines, once you said the guidelines is not the Holy Bible. And we have to look each case as an individual case. I have a question for you. In this guideline, concerning the guidelines, in these guidelines, it's very clear what are the worrisome features for branch type IPMNs. But when we look at main duct, the ones that have 5 millimeters or more, but less than 1 centimeter, right? Still, it is a main duct IPMN. Still, it is a disease that is different than branch duct type. It's more aggressive. But how do you manage this IPMN's main duct that have only worrisome features? Do you treat aggressively as a main duct IPMN, or do you feel more comfortable in watching and waiting it?
Thank you, Eduardo, for pointing this out, because it is a real case, the one that you are asking me about. And of course, I mean, there is no yes or no question. Okay, we're living in a sort of like gray area, right? So we have no either red or blue pill in this case. So the first thing I tell you is, when I deal with these cases, I really want to be sure I'm dealing with a main duct IPMN. So let's assume that we did everything we can to confirm it's actually an IPMN. So I just want to know if there is mucus inside. So I'm going to ask my endoscopist, avoid any biopsy. I don't need any biopsy. I just want to assess whether there is the fish mouth papilla, if it's in the head, or if you stick a needle inside, just tell me whether there is mucus or a high CEA or low glucose. So in other words, I want to be sure I'm dealing with an IPMN, even by assessing the clinical history, saying that the patient is not a heavy smoker or a heavy drinker. I want to avoid diagnostic mistake, even if I'm not able to in 100% of cases, actually. Second point, what about the patient? It makes a huge difference if this main duct IPMN is found in a healthy 60 years old individual or in a 85 plus patient with a lot of comorbidities. In the second case, okay, by scaling the pros and the cons of a surgery, this IPMN will never make it to overt cancer, okay, at least before anything else happens to this patient. And we even have to consider the specific risk of surgery. But main duct IPMN between 5 and 9 millimeters, as you said, in younger individuals are actually way challenging, because in this case, we really have to, define the pros and the cons of going for surgery. Probably this type of patient will likely benefit from surgery. But again, if duct dilation is the only feature that we have, so we exclude any solid component, there is no jaundice, okay, then we have time once again. So probably this patient will require surgery, most likely yes, but again, this is not something we have to be done in a week or so, okay? So we can, again, prepare for the surgery. What about the BMI, for example? If I find such an IPMN on an obese patient, well, I have time then to ask my patient to get fit for the operation. Could take 6 months, could take a year. Is it an issue for the IPMN progressing to cancer? It's not. It's not. So we have a scenario which is completely different from that we face when it comes to pancreatic cancer. It's a complete different story. Did I answer to your question?
Yes.
Okay.
Another question for you concerning the technique, the surgical technique. We know that IPMNs are the perfect case to learn how to do a pancreatic resection, because we have no solid tumor, we have no vascular invasion. We can have some pancreatitis, but it's easier than a cancer surgery. On the other hand, it's the most challenging for reconstruction, because we are dealing with a soft pancreas and sometimes small ducts after the resection of the dilated duct. Do you think how do you face robotic surgery in pancreatic resection, especially in IPMNs?
Oh, I hear you, Eduardo. You're touching, I think, different aspects, all of them being very important. So, well, if the question is about robotic surgery, we have now data out there, basically showing us that it's actually better, even better than open. So, you cannot be against or pro robotic surgery. It has to be proven yet that it's superior, but definitely not inferior, particularly when it comes to surgery not performed for overt cancer. Again, I don't think this is the key factor. The key factor is patient selection. So it's way more difficult to select the surgical candidate than operating them via minimally invasive surgery or open surgery. I think there are a couple of great examples on when robotic surgery can be a game changer, like you were mentioning the small duct. Then you can actually see the small duct way better with the robotic surgery. I mean, I myself have this experience, but again, it has to be clearly proven in randomized controlled trial that then the outcomes are better. It is just a feeling. Let's be clear on one point. When you deal with IPMN, try always to be conservative with your surgery. There is actually a very limited role for total pancreatectomy upfront, like per se. In many resections, you can do a partial resection of the pancreas, and then you can do intraoperative pancreatoscopy if it's a main duct IPMN, or ultrasound while in the OR to check the rest of the pancreas, and you can avoid a total pancreatectomy even in main duct IPMN. And again, this can be done either open or with the robotic. Robotic surgery has other issue when it comes to pancreas. We have now trials to say that it's not inferior to open technique. But again, this has to be performed in centers of expertise, because it is not only about the surgeon, it's about the entire hospital where the patient is treated. I mean, you can be extraordinary in your surgical skills, but then if you don't have a 24-hour service in endoscopy, interventional radiology, angiography, then you know you're going to have complications you won't be able to deal with. So rather than having a robot, I think it's even more important to have a good anesthesia team, a good interventional radiology, and a good endoscopy. And I say it from the surgeon perspective.
And what's your opinion about enucleation of branch duct type IPMNs?
Yeah, so this is like something that my French friends are doing, and I have the utmost respect for them. I think from the conceptual standpoint, this is wrong, because I would either go for proper oncological resection because I suspect there is cancer there, or I would just watch this cyst, you know? So I would be then, either going for a normal pancreatic resection. What am I gonna do if my enucleation will find out that I have cancer then? Well, the obvious answer would be to go for surgery again, because I wanna have a frozen section, which is impossible with enucleation. I would like to have a proper lymphadenectomy, which is not, of course, always performed when it comes to enucleation. So I am more philosophically against this technique, even if I know that there could be very nice resection, for example, of the uncinate process or just of the cyst, particularly with the robot. But again, why should we perform such a non-oncological resection if we have the suspect that this cyst is somehow changing or has some high-risk stigmata or worrisome feature? So I am against, not because I know it is not feasible or safe, even though we know fistula rate after enucleation can be very high, but I am against because surgery for IPMN should be oncologically driven whenever you have the suspect that you have even a small cancer in the cyst.
Okay. One last question for you, since we are talking, and I'm glad to be talking with an expert. I have a real case that I saw yesterday on my private office. It is a 60-year-old female fit with a main duct IPNN in the head. I mean, a mixed type. Main duct in the head with surgical indication, 8 millimeter duct, and trivial cysts, lots of them, on body and tail. How do we approach this case of mixed type, but when the branch duct component is small trivial cysts?
So in this case, you have a clear target, which is the head of the pancreas. So I would definitely avoid, going for total pancreatectomy. I would go for a Whipple, or in Italy we used to preserve the pylorus, so would be pancreaduodenectomy, and I would assess the frozen section to avoid leaving behind high-grade dysplasia. The trivial cyst will very unlikely be of any, high-grade nor invasive component. So again, I would leave them alone. Anyway, this patient will require follow-up. Doesn't matter. So you will keep watching the stump if you leave it there. One adding thing you could do in the OR, as I was mentioning before, would be to go for a pancreatoscopy. In this way, you could also see the duct and perform biopsy, not just at the level of the transaction, but also to avoid skip lesion at the end of the tail. But again, my advice would be to talk to this 60-year-old patient. Let's see whether she's worried about having a cancer or reluctant to undergo surgery, because once again, you have time. So do all the efforts to be sure, okay, do your best to confirm the diagnosis of mixed type IPMN. Once you have it, well, then because of the presence of a relative indication for surgery, you should talk to the patient about surgery. And if you can do it minimally invasive, even better for you and the patient. Maybe the duct at the neck is not so small in this case because you have a mixed type IPMN. So if you have a decent duct, then you probably have also a good sealing anastomosis. And yeah, and try to take this decision according to the patient that you are facing. So 60 years old, we expect more than 25 years in terms of life expectancy. So I think surgery should be absolutely considered in this case. Doesn't matter. But for the trivial cyst, if they're really trivial, probably you cannot still do it because we define trivial only after 5 years of stability. Well, they will reveal their biology year after year. But anyway, you will keep following up this lady.
Any concern about the type of anastomosis when you leave a pancreatic remnant with cysts? Do you think it's better?
That's something I probably never thought about. So I don't think so, because you know that the duct mucosa I mean, either you do it with a Bloomgart, modified Bloomgart, or just with a, double layer anastomosis, it is actually the most important thing. So in terms of avoiding a fistula, if you have a big duct, then I would definitely,
I mean, in terms of thinking that this patient might need a repancreatectomy in the future if the cysts
if this
evolve.
happen, I mean, if this happen, then I mean, this would not actually change my practice. I mean, I can add, but this is just speculating that if you do a pancreaticogastrostomy, then you still have a way to scope the main pancreatic duct. Honestly, this would not be a major driver for my anastomosis. I mean, I think that in this case, the risk for fistula won't be that high, based again on the fact that you have main duct IPMN. So it means that the duct is dilated. So I would say do your best. Do the anastomosis you feel the most comfortable with. There are no data whatsoever on which one is better in this case. So yeah, I mean, you can do completion pancreatectomy if in any case in 5, 10, 20 years this would be actually the case for, but I don't see how this would impact in my anastomotic technique.
What's your preference in terms of anastomosis?
Well, I mean, it's not a preference, Eduardo. So I really think that we need to be tailored. So we need to know at least, I would say, 3 to 4 different anastomosis to adapt our technique on, the gland we're dealing with. There are trials actually assessing that there is not a significant difference between PJ and PG. There is a slight evidence in favor of pancreaticojejunostomy when it comes to difficult anastomosis, but not in terms of fistula. It's more about the burden of complication. We know there is a role for stent, either internal or external, if the risk is high. If the risk is low, doesn't really matter. You can do whatever you feel more confident with. No role for routine use of somatostatin analogs, no role. So select your patient. What I really love, and I've been taught about this from our Finnish friends, there are 2 trials on endosurgery actually, is maybe the use of cortisone during the operating room if your pancreas is very soft and rich in acini. That means that it's very juicy. It produces a lot of juice. But again, I mean, do the anastomosis you feel more comfortable with. In my case, for the risky pancreas, would be a PJ, double layer with ductal mucosa, with a stent, external stent, and with the use of cortisone during the OR. So I call this mitigation strategy, which means I know something bad will happen. I do my best to try to lower down the effect of the storm.
So you don't like the PJ, the PG.
No, it's not that I don't like, but we performed a trial on that, and so as I have a level 1A evidence that PG is actually better in terms of burden of complication, I try to be as much as possible evidence-based. But I like pancreagastro. I mean, if you do middle pancreatectomy for a neuroendocrine with a robot, it's very nice then to just lift the body tail and do a pancreagastro, for example. So no, in surgery we need all the tools, tools.
So
I think
you select according to the case. You're not radical as I've been to Heidelberg, and they are very radical in just doing.
Yeah, but I mean, in Heidelberg, they're my friends, now that the boss there is Chris Mikalski, and this guy is very open, to also, adapt the technique according to the case. I think that even our German friends would agree that we really need to be able to customize our technique according to the specific case we're dealing with.
Okay, we could stay here and talk for hours, but unfortunately we have to end it. And I can't thank you enough for being with us. It was really an experience. And I hope we can be together in presence. We are organizing our symposium maybe next year of our Pancreas Club in Rio, and I'll try to invite you to meet us in presence.
Thank you very much. It will be my absolute pleasure. Probably you
Okay.
can teach me some soccer now that the Italian team is so bad in Brazil.